Assalamu alaikum. On behalf of Ahsan Academy, let me welcome you to a presentation on general organization of abdominal wall. This is the part 3 presentation on a series of presentation on the same topic. In this third part, I will discuss the general organization of the muscle in the wall of the abdomen, structure function relationship, and the formation of Rectus sheath as well as the formation of the inguinal canal. Every stage they try to correlate clinically. This you can see the muscles of abdomen. These are the lateral and becoming anterior, so anterolateral muscles of the abdomen. We know the name. These are the external oblique muscle, internal oblique muscle, and transversus abdominis muscle from outside to inward. So let us try to understand the muscular fiber orientation. The external oblique muscle, the fleshy part lies superlaterally. It occupies the superlateral part of the abdominal wall. The fibers runs medially and inferiorly. So fibers directed inferior-medially mostly. On the other hand, this internal oblique muscle occupies relatively lower position. The flesh remains in the inferior part, and the fibers of the muscles mostly run superior-medially. So they are in counter direction. So in the midline, they decussate. The fibers decussate with each other. Means the external oblique muscle fibers become continuous with the internal oblique muscle aponeurosis and the fibers. So these two muscles together making a digastric muscle means tendon connecting two bellies of muscles, so they work together as an unit. So the external oblique muscle of one side makes an unit with the internal oblique muscle of opposite side, and together you can see this is making unit with opposite side and this is making unit with the opposite side. So there are two digastric units of. You can see this muscle on either side, so they can contract together or one side, make helping in flexion and rotation, bringing the shoulder. You see, this is the shoulder going towards the opposite hip joints. So this type of movements are done simultaneously by the external oblique and opposite internal oblique, and other side the muscle remain relaxed. In this way, by simultaneous contraction, this can do various movements of the spine. When they contract together, it causes increase in the intra-abdominal pressure. You can see this upper part of the abdomen is sealed by the diaphragm, and below the pelvic diaphragm closes the outlet of the pelvis. So it is a closed cavity. When abdominal muscle contracts, this is depressed, so increased intra-abdominal pressure is the result. The increased intra-abdominal pressure presses perpendicular in all directions, so it pushes the diaphragm, and by this it aids in several movements and leading to breathing, forceful breathing, coughing, and sneezing. This also presses all the viscera, and this assists in doing some normal physiological actions like defecation, micturition, and childbirth. The third layer from outside is the transversus abdominis. You can see the fibers run almost, fleshy parts occupy the lateral part and fibers runs almost transversely. So this fuses with or decussates with the fibers of opposite side, making similarly on digastric muscle and work as a single unit. So when the transversalis muscle contract, there will be tremendous increase in the abdominal intra-abdominal pressure. So the compression on the viscera and the diaphragm will result, as I have discussed earlier, the sneezing, coughing, forceful breathing, and physiological processes like defecation, micturition, and childbirth. Now, rectus sheath. It's a sheath of the rectus abdominis muscle. You can see this is the anterior covering of the rectus abdominis muscle, and the muscle cannot be seen here. So this is anteriorly covers the whole length of the muscle and fuses with the periosteum of the bones and ligaments. This below also, and this symphysis pubis. So they covers the whole surface and it fixed upper and lower end. You can see this anterior layer is removed. This is anterior layer is there, but here the anterior layer is removed. The posterior layer is not complete. It is covering the upper 2/3 of the muscle, and below it is absent, and this free margin is called the arcuate line. This lies at the level of anterosuperior iliac spine. This is the anterosuperior iliac spine. So at this level, it ends as arcuate line. Rectus sheath is different at the different level, and the variation is because of the muscular attachment, and it is contributed by the three anterolateral muscles. You see, we can draw, this is the costal margin. Internal oblique and transversus abdominis remains attached to this, but external oblique continues. So there is variation above this, and this is the anterosuperior iliac spine. This is one margin, and this is anterosuperior iliac spine, and in between this part is has different organization. This is between the costal margin and level of anterosuperior iliac spine. So below this, another type of rectus sheath we observe. Let us discuss. So above the level, it's having anterior layer that is formed by the aponeurosis of the external oblique muscle. As we know that the middle layer and the internal layer, this is internal oblique and transversus abdominis remain attached to this margin, so they cannot continue. So this rectus muscle lies directly on this. You can see this costal cartilages and intercostal spaces. So this is formed by the posterior wall is on the rectus muscle is on this. There is no sheath above the costal margin. It looks like this. This is the rectus abdominis muscle, and you can see this is the aponeurosis of the external oblique proceeding above and fused in the linea alba attached to the xiphoid process and sternum. These are the ribs, costal cartilages, and this is the intercostal spaces. So rectus abdominis muscle directly lies on it. There's no sheath on the posterior. In between these two, this is the main part, and this is having two walls, anterior wall and posterior wall. And you can see this is the cross section, rectus abdominis muscle on either side, and you can see the three flat muscles are there, and aponeurosis running either anterior or posterior part. So this aponeurosis of the internal oblique, you see this is coming to the lateral margin of the rectus abdominis, splits to form two layers and fuses again, and it fuses with the opposite side in the linea alba. So this is the linea alba part, and this is fusing there. The external oblique muscle, you can see this dot line. The aponeurosis proceeds anteriorly over it, and it goes to the linea alba and fuses with the opposite side and with the same side aponeurosis. The inner layer is formed by the transversus abdominis. So the inner layer is the posterior lamella of the internal oblique muscle and the transversus aponeurosis together forming this one. Uh, and similarly on the anterior, the splitted anterior layer of the internal oblique and external oblique aponeurosis, and all these fuses in the midline forming the linea alba. The part below, this is the line indicating the anterosuperior spine level. At this level, you can see all the three aponeurosis going anteriorly. So posterior, there is deficiency. No aponeurosis is there. So the anteriorly, the three anterolateral muscle aponeurosis fused together means external oblique, internal oblique, and transversus abdominis together making the anterior layer and fuses with the opposite side in the linea alba. You can see this on this is posterior layer, and it is deficiency below the line of anterosuperior iliac spine, and this margin is known as arcuate line. So below arcuate line, directly muscle remain on the fascia transversalis, as I have shown by changing the color. This is the fascia transversalis. So it is directly on the fascia transversalis. So let us summarize the sheath formation. So above the costal margin, the rectus sheath is present on the anterior aspects only, and this is the external oblique aponeurosis. And the muscle directly rests on 5th, 6th, and 7th costal cartilage and intercostal space between them. Below the arcuate line means anterior superior iliac spine, level of anterior superior iliac spine, all the three flat muscles, external, internal, and transversus abdominis fuse together to form the anterior layer, and the posterior layer there is no aponeurosis. The muscle directly rests on the fascia transversalis. So only there is anterior layer like this one, but there are three muscles, fusion of the three muscles there. In between, this is the major type. You see the anterior layer is formed by the external oblique aponeurosis and the splitted anterior lamella of internal oblique. Posterior layer, splitted posterior layer of the internal oblique and transversus aponeurosis fused together, and they again all unites in the medial margin to form the linea alba. This is a very easy figure to draw, so students can easily draw this type of figures to discuss the formation of rectus sheath. The rectus sheath contains two muscles, one large muscle that extends throughout the length, and it is rectus abdominis. This a small triangular muscle is in the medial part of the lower part, and this is known as pyramidalis. So these two muscles are there, and this rectus abdominis actually is the main muscle remaining inside. You can see the nerves. So spinal nerve. So anterior rami of the lower 6th thoracic spinal nerve pierces this muscle and remain in the space. You can see on this side, these are the superior and inferior epigastric vessels that lies in the rectus sheath. One is coming down and one is coming from below. And lymphatic vessels, minute vessels remain there within this. A small amount of fat is also there. External oblique aponeurosis has important role in the inguinal canal formation. The lower free margin of the external oblique muscle extends from the anterior superior iliac spine to pubic tubercle. This part enrolled inside and is thickened The medial half of this enrolling forms the floor of the canal, and the lateral two-third actually gives attachment to the internal oblique muscle, and lateral one-third gives area for the attachment of the transversus abdominis. So these together helping in formation of a canal, oblique canal in the lower part of the abdomen. This external oblique aponeurosis forms an opening which is triangular in shape. You can see the color change, and this is known as superficial inguinal ring. And you can see this is a triangular defect in the external oblique aponeurosis. It is situated just above. This is the pubic tubercle, so it is just above the pubic tubercle and extending to the medial side. So we can easily identify this pubic tubercle on a body. So it is easily identifiable that this is the position of the superficial inguinal ring up to the medial part of this. You can see this is the place for the superficial inguinal ring. The deep inguinal ring is a defect. This is the fossa transversalis. It's an oval opening in the fossa transversalis. So deep to this area. So this is in between the anterosuperior iliac spine and pubic symphysis upper part. So if we draw a line, this is in the midpoint of this line, just above the inguinal ligament, so about ½ inch above the inguinal ligament. This is the position. So it is the midpoint between these 2 points, anterosuperior iliac spine and upper part of the symphysis pubis. If we draw a line at the midpoint, you will get the deep inguinal ring, and it is in the fossa transversalis. You can see this is the deep inguinal ring shown on the right side figure. That is the clinical significance. It's a weak point. You can imagine this there deficiency in defect in the fossa transversalis, and it is external oblique aponeurosis. So this posterior wall is weak here and anteriorly supported by some muscle. Here this is anteriorly deficit, so posteriorly that is supported by natural muscles. So this is the deep inguinal ring, and the deep inguinal ring lies lateral to the inferior epigastric vessel. That's a good clue for the surgeons to identify the type of the disease, type of the problem. So we should try to remember the position of the deep inguinal ring in relation to the inferior epigastric vessels. In a different way, we can say the ring is lateral to this, or artery is medial to the ring. Superficial inguinal ring, this is defect in the very strong external oblique aponeurosis. So this is anteriorly, this is weak, but posteriorly this is supported by the fused tendon of internal oblique and transversus abdominis, that is known as conjoint tendon. So this we will see again. This is the conjoint tendon, that is a good support of the superficial inguinal ring. So superficial inguinal ring posteriorly supported by conjoint tendon. Similarly, the deep inguinal ring is supported by the strong, thick fiber of internal oblique muscle and transversus aponeurosis. This is external oblique aponeurosis, and this is the internal oblique muscle. The features: the inguinal canal is obliquely placed, and it's a passage of about 4 centimeter long, and you can see this is extending from the deep inguinal ring to the superficial inguinal ring. You can see up to this. You can see another figure. This is the deep inguinal ring, and this is the superficial inguinal ring. This is a small oblique passage between these two on the inguinal ligament. This is groove part. So it's a deep one is the opening in the fossa transversalis, and this is defect in the superficial one is the defect in the external oblique aponeurosis. You can see this is the canal area. Floor can be seen. This is a curved drain-like area of the medial half of the inguinal ligament. How the boundaries of the canal is formed means the walls are formed. So you can see this is the floor. So floor is formed by the inguinal ligament. It is actually medial half of the inguinal ligament that is forming the floor. You can see this is the external oblique aponeurosis making some curved. This is curved medially and forming this groove. So this is the floor of the inguinal canal extending from midway up to this point. You can see after removal of the anterior wall. So anterior wall, you can easily understand this is the opening. So rest of the part anterior wall is the external oblique aponeurosis. This is the external oblique aponeurosis. Now it is the ring is at the middle, and internal intercostal muscle extends 2/3, so it overlaps. So lateral part is overlapped by the internal oblique muscle. So anterior wall is aponeurotic up to the half point, this point 2/3. This is medial 1/3. Then the fleshy internal oblique joins then to form the anterior wall of the inguinal canal. This is the deep ring you can see in the fossa transversalis. And anteriorly you see this ring is supported by this fleshy internal oblique muscle and the external oblique aponeurosis. The roof is formed by the arch fiber. You see this is attached up to the lateral 2/3, then it fibers arches over the roof and goes to the posterior wall. This is transversus abdominis. This is internal oblique, and this one is the transversus abdominis. That is also arches over. So these two forming the roof. This is the opening, and this is the opening. Over that it is passing. So this roof is formed by this arch fiber, both muscle. The posterior wall, you can see this is fused together and forming the posterior wall. So this is medial part is formed by the conjoint tendon. So medial part, it is the internal oblique, and this is the transversus abdominis. They fuse together to be the posterior wall in the medial part, and this conjoint tendon lies behind this superficial ring. So this is a very good support. So conjoint tendon is a strong support to the superficial ring. The deficiency is overcome by the protected by this conjoint tendon. And the lateral part, it is the fossa transversalis that is only forming the wall behind. Why this canal is there? For the male, this is actually transmitting the spermatic cord that contains the structure run between the testes and the abdomen. There are several structures passing through this in case of male, but in female this is relatively narrower and contains on the root ligament of the uterus. You see this is the spermatic cord, contains several structures. These are the name of those structures. First difference: testicular artery, pampiniform plexus and becoming the testicular vein, testicular lymphatic vessels, autonomic nerve plexus, remains of the embryological processus vaginalis. It's an embryological structure, and genital branch of genitofemoral nerves. All these we will find in some sheath, the spermatic sheath of the spermatic cord, and we have already discussed that few fibers of the internal oblique joins this sheath, that is premenstrual muscles. So together covers all these structures and runs through this canal in case of male. In female, this is roundly, this canal is very narrow and main structure is round ligament of the uterus. Thank you very much for remaining with this presentation.